Good morning. This is Babak, Larian. I'm really happy to be here. It's another Parotid Facebook Live Q&A session, and just really wonderful to be able to be doing on this platform and reaching so many people and really being able to help out from long distances away. And a very good question that we were asked today comes from actually Scotland. So let me read through the question so that I can address it and then get into it. Gary asks, I had surgery in April 2018 to remove a tumor in my parotid gland. Excuse me. Pathology results showed adenocystic carcinoma. Had 6 weeks of radiotherapy, all good afterwards, but a month ago I felt a very small lump, half the size of a pea where my tumor was. My surgeon put me for a CT scan and also an ultrasound and FNA. Biopsy results came back as it looks as though it's adenocystic again. So it looks like a recurrence. Sorry to hear that, Gary. Due to get this lump removed, small incision in my cheek this time, what are the chances of yet another reoccurrence? Any advice and information is greatly appreciated. I'm in Glasgow, Scotland. All right, Gary, best of luck on your surgery, but let's talk about it. There's a lot of cancers that can occur in the parotid gland, and in the salivary glands in general. So the World Health Organization has kind of come up with a designation system for salivary gland cancers, and the most common type is called mucoepidermoid. The second most common is called adenocystic in all of the salivary glands: parotid, submandibular, sublingual, and the minor salivary glands. In all comers, mucoepidermoid is the most common, adenocystic second most common. Now, as this is combination of parotid. In the parotid, mucoepidermoid tends to be more common. In the submandibular gland and the minor salivary glands, this adenocystic tends to be more common. But when you look at all comers, because there are more tumors happening in the parotid gland, this shows the dominance, right? It is a very unusual tumor. It has very interesting characters to it. It is relatively slow growing in comparison with the other aggressive cancers of the parotid that tend to want to invade the nerve and so on. It has a huge affinity for the nerves, for any kind of nerve. So in the parotid, it ends up being an affinity for the facial nerve, and that makes it very interesting because it can be a very small tumor, but as soon as it jumps on a nerve, it starts moving along it. And so it can be hard to treat because it uses the nerve as a highway in a sense. And so once it latches onto a nerve, it takes off in any direction. And so it becomes a challenging tumor to treat because most other tumors of the parotid gland, when you can peel the tumor off the nerve, right? So if this is the nerve and there's a tumor, and you can clearly peel the tumor off the nerve, then you're satisfied that perhaps with radiotherapy you can address what may be on the nerve. But in adenocystic, the tumor not only goes on the nerve and can invade and cause paralysis, but it can also use the nerve as a mode of transport and move along the nerve. And it's not contiguous, it can be skip lesions. So you can have this, and then there can be another piece here and another piece there. So this skip lesion phenomenon makes it even harder because you don't even know where the beginning and the ending of the tumor tracking on the nerve is. And that's one of the things that makes adenocystic very, very interesting. But let me share with you more. So it is the most common cancer in the submandibular and the minor salivary glands. It happens other places too, on the palate, in salivary glands, on the palate, lips, base of tongue, nose. It is slow growing. It is locally invasive, meaning that it tends to erode into local stuff a lot. and including nerves and other tissue. More than 50% find a nerve and track on it. Metastases to the lymph nodes are more rare, okay? And but as the tumor gets bigger, the chance of the lymph node metastases goes higher. Distance metastases are fairly common. So 40% usually to the lungs and then the bones. And these metastatic rate can be very, very variable based on the size. So in a T1 lesion is 30%, in a T2 40%, and then as you get to the more advanced stages, it can be even much higher, right? And then the recurrence is 30 to 40% of the time. So Gary, when you're asking what is the recurrence rate, 30-40% of patients have a recurrence, but that recurrence tends to be more if there was nerve involvement. So if on your original tumor, they wrote on the pathology report perineural invasion, then the chance of recurrence is higher and higher. And if you didn't have any nerve involvement, which I would hope that was the case for you on your original surgery and pathology report, then the chances of this after this recurrence coming back is lower. But if there was nerve involvement, the chances of the recurrence is higher. And hopefully if there was a nerve involvement, they tracked along the whole nerve, right? So if the tumor was here and went on the nerve there, a skip lesion, right? So here and a skip lesion there, when the radiation is done, they should consider the whole course of this nerve, right? And radiate not only tumor and adjacent site, but the course of the nerve, just in case there are more skip lesions, so it can be radiated. So that's important in how you're being treated, Gary, and that's really vital, and it, it helps answer your question. So moving on to more information. So median time to recurrence, 8 years, right? What that means is that, of course, you got a recurrence within a year, but it can take up to 8 years to get another lesion in the same spot. So this is not the type of tumor that after a year or two, or after 5 years, you can say you're cured and done. This is something that needs to be monitored for a lifetime, okay? And the median survival when people have metastases. So when someone has a metastasis to the lung, on average, they live another 6 years. Now, the pathology formation of the tumor can affect the final outcome and the prognosis. The more cellular it is, the solid pattern, the more aggressive it turns to be. So the things that matter is size, margins on surgery. If the margins were negative, very good. Histology, again, which one of these types? Location, obviously some glands are more forgiving than others, have more room, and allow you better removal. And radiation treatment is usually for patients who have either positive margins, perineural invasion, bone invasions, lymph node metastases, or recurrence. So those are definites, and the other ones are based on how you feel, based on how the surgeon or your physician's perspective is on what they saw during surgery and how they feel the aggressiveness of your tumors. And then the survival statistics is really odd for this thing, because at 5 years, 70% are alive. At 10 years, 30%. At 20, 10%. So it's hard to know when you have achieved a cure, okay? So the role of radiation therapy, University of Iowa had a large number and looked at them, and that's 183 patients. And if they did radiation treatment alone, at 5 years, 26% were alive, and at 10 years, none. So radiation alone is not a very good option. Surgery alone, 72% at 5 and 42% at 10. Surgery and radiation, so they said that radiation did not improve local control or survival. chemo did not improve quality of life or survival in patient with distant metastases. So there was a lot of data on there. There's more recent data coming out of the Boston group that does show a favorable outcome with radiation therapy. So I think radiation therapy is controversial, okay? But I think I disagree with the University of Iowa data in that I do believe there is a role. You have to be selective in about patients. You can't just give it to everyone. When you give it to everybody and just look at the data, you probably will have a skewed view because it washes it out. But if you select patients who have more aggressive disease and so on, there are clear advantages, okay? And in terms of facial nerve sacrifice, there is an advantage when there is a facial nerve sacrificed. There's in terms of locally, absolutely at 5 and 10 years, there is no recurrence locally. But when you look at this data, you may feel that it's skewed because patients who had their facial nerve not sacrificed meant probably that they didn't have nerve involvement, and that makes it a less aggressive and a less recurrent disease, right? So when it wasn't necessary to remove the nerve, based on this data, 100% survived at 5 years and 100% survived at 10 years. And so that's an important statistic, Gary, for you. So if your facial nerve was not involved, your outcome and final prognosis is very favorable. Okay. In any case, let me turn around. So adenocystic, very strange disease, slow growing, relentless. All the patients always need to be monitored. We always have to look at them. Sorry about the construction going on in the background. In any case, and you really have to treat it aggressively and monitor it for a lifetime. I would say, Gary, if you didn't have perineural invasion, having a surgery that's more minimalistic at this point is sensible. If you did, then you may consider more aggressive treatment. Or if your surgeons feel that this tumor could be close to a nerve, I would say that would be the case as well, that it should be a more aggressive treatment. But if they feel that this is an isolated tumor and it's away from the area of the facial nerve that was left behind, then they may do a more minimalistic surgery and be able to address this. All right. So best of luck to you, Gary. I hope you do well. Chris is asking a question. Upcoming surgery, pleomorphic adenoma with vascular involvement. The complication does this add to the surgery? If you mean that the pleomorphic adenoma is wrapping around a blood vessel, Chris, tell me which gland you're talking about. If it's the parotid, then the blood vessels in the superficial area at least are very minimal and they can be easily removed without any consequences. If it's in the deep lobe and you're talking about the carotid artery, then that probably is not a benign tumor that's involving a big blood vessel, and I would question that. And if it's in the submandibular gland, then again, it all depends what blood vessels you're talking about. Because if the blood vessels are the ones in the submandibular gland, they can be easily removed as well. So if Chris is saying it's in the left parotid, if the tumor is superficial, on the more superficial aspect, Chris, then you don't need to worry about it. You can sacrifice it. I would just caution that perhaps, and I'm sure your doctors are doing this, that perhaps during surgery they should re-look at the specimen while you're in the operating room to make sure that it's still benign and all parts of it are benign, because this is not a typical behavior of a benign pleomorphic adenoma to involve the blood vessels, right? And And by doing that, you'll have confirmation during surgery, and your surgeons will do the right thing. I'm certain that that's what they're going to do anyways, but this is information for you to know and to discuss with your surgeons, so that you are aware of a plan. And when you, as a patient, know the plan, what the plan is, then you'll be more capable of making decisions and guiding your surgeons as to the things you would want to have done, and have more balanced expectation from your surgery, I would say. But blood vessels in the parotid, and at least the superficial aspect of the parotid, are very redundant and can be easily removed without any consequence whatsoever. The blood vessels that are deep in the deep lobe, or not in the deep lobe, adjacent to the deep lobe, meaning the carotid artery, the artery that goes from your heart to your brain, obviously a vital structure. If that's the one that is in question, then there needs to be a very important discussion about what surgery you're having, what needs to be done to those blood vessels, and what preparations your surgeons are making to address them. Okay, best of luck, Chris. It can be hard. Some of this medical lingo can be unclear and difficult, and so it can be hard to understand what they mean when they say that either on a pathology report or on a imaging study. Again, sorry about the background noise, but best of luck. If there's any more concerns or questions, please contact me and I'll help you guide you through it. All right. I hope you guys find this to be helpful, and it's wonderful to be here to try to reach out and help as many people as possible. Have a wonderful day. Bye.